नमस्ते बेटिया हमेशा खुश रहो बेटिया A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this lecture today, we are going to continue with the thyroid disorders, and we are going to discuss about thyroiditis today. Thyroiditis, that is inflammation of the thyroid gland. Thyroiditis can be acute, it can be subacute, or it can be chronic. Acute thyroiditis is basically due to bacterial, fungal, or radiational causes. Bacterial infection. The bacterial infection is caused especially by Staphylococcus, Streptococcus, and Enterobacter. The fungal infection is caused by Aspergillus, Candida, Coccidioides, Histoplasma, and Pneumocystitis. Radiation therapy thyroiditis occurs mostly after iodine 131 treatment. The subacute thyroiditis, it can be viral, that is granulomatous thyroiditis. It can be silent thyroiditis, that includes postpartum thyroiditis, and drug-induced thyroiditis. The chronic thyroiditis can be caused due to three causes. Number one is autoimmunity, that is focal thyroiditis, Hashimoto thyroiditis, atrophic thyroiditis, and Riedel's thyroiditis. Next, we have parasitic thyroiditis, that is caused by echinococcus, strongyloidiasis, and cysticercosis. Then we have traumatic cause for chronic thyroiditis, that is after palpation. If more and more palpation of the thyroid gland is done, it can cause injury in the thyroid, leading to chronic thyroiditis. Now let's start with the acute variety, acute thyroiditis. Acute thyroiditis is a rare and due to suppurative infection of the thyroid gland. The patient presents with thyroid pain, often referred to the throat or ears, and a small tender goiter that may be asymmetric. There can be fever, dysphagia, and erythema over the thyroid, and these are common with systemic symptoms of febrile illnesses and lymphadenopathy. The erythrocyte sedimentation rate, that is ESR, and white cell count, that is WBC count, are usually increased, but thyroid function is normal. Next, we have subacute thyroiditis, that is also known as D. Quervain's thyroiditis. This is a very important thyroiditis, and it is most commonly asked in examination, that is D. Quervain's thyroiditis. So D. Quervain's thyroiditis is a granulomatous thyroiditis or viral thyroiditis. It is caused by viral infection, that is mumps, Coxsackie virus, influenza, adenovirus, and ecoviruses. The symptoms can mimic pharyngitis. The peak incidence occurs at 30 to 50 years of age. The women are affected 3 times more frequently than men. Next, we come to the pathology, that is subacute thyroiditis. Pathology of subacute thyroiditis or the D. Quervain's thyroiditis includes a characteristic patchy inflammatory infiltrate with disruption of the thyroid follicles. During the initial phase of follicular destruction, there is a release of thyroglobulin and thyroid hormones, leading to increased circulating T3 and T4 levels and suppression of TSH. During this destructive phase, radioactive iodine uptake is low or undetectable. After several weeks, the thyroid is depleted of the stored thyroid hormone, and a phase of hypothyroidism typically occurs, with low unbound T4 levels and sometimes T3 levels and morbidly increased TSH levels. The radioactive iodine uptake returns to normal or is even increased as a result of rising TSH levels. Finally, the thyroid hormone and TSH level returns to normal, as the disease subsides, usually several months after onset. Next, we come to the clinical features of subacute thyroiditis. The patient usually presents with a painful and enlarged thyroid gland, sometimes accompanied by fever. There may be features of thyrotoxicosis or hypothyroidism depending on the phase of illness. The patient typically complains of a sore throat, and examination reveals a small goiter that is exquisitely tender. There is pain often referred to the jaw or ear. The complete resolution is usual outcome, but the late onset permanent hypothyroidism occurs in 15% of the cases. Now, lab evaluation of subacute thyroiditis. The thyroid function tests are characteristically evolved through three distinct phases over about 6 months. There are three important phases. First of all, there is thyrotoxicosis state. Then we have a hypothyroid phase, and then there is a recovery phase. So in the thyrotoxicosis phase, first of all, T3 and T4 levels are increased and TSH is suppressed. There is high ESR and low uptake of the radioiodine, and the WBC count may be increased and thyroid antibodies are negative. FNA biopsy may be useful. Now, after this thyrotoxicosis phase, all the stored thyroxine hormone is released, and due to the destruction of the gland, there is a state that is known as the hypothyroid phase. When there is less production of thyroid hormone, thyroxine hormone, due to which hypothyroid phase occurs. Then what happens is slowly and steadily there is recovery phase. Recovery phase when there is repair of the gland and there is increased production after the hypothyroid phase of the thyroxine hormone, due to which the recovery phase occurs and the level of the thyroxine gets back to normal, and also the increased TSH level which was found in the hypothyroid phase comes back to normal. Now we come to the treatment of the subacute thyroiditis. Large doses of aspirin or NSAIDs are sufficient to control the symptoms of many cases. The local or systemic symptoms, glucocorticoids should be given. Thyroid function should be monitored every 2 to 4 weeks using TSH and unbound T4 levels. Levothyroxine replacement may be needed if the hypothyroid phase is prolonged. Now we come to silent thyroiditis. Silent thyroiditis is the painless thyroiditis or silent thyroiditis. The patient with underlying autoimmune thyroid disease, and it occurs in up to 5% of the women with 3 to 6 months after pregnancy, and is termed as postpartum thyroiditis. Thyrotoxicosis lasting 2 to 4 weeks is followed by hypothyroidism for 4 to 12 weeks and then resolution. It is associated with the presence of TPO antibodies antepartum. The silent thyroiditis can be distinguished from the subacute thyroiditis by a normal ESR level and the presence of TPO antibodies. Severe thyrotoxic symptoms can be managed with a brief course of propranolol. Thyroxine replacement may be needed for the hypothyroid phase, but should be withdrawn after 6 to 9 months as recovery is a rule. Annual follow-up thereafter is recommended. Next, we come to chronic thyroiditis. Chronic thyroiditis is associated with serological evidence of autoimmunity, particularly the presence of TPO antibodies. Next, we have Hashimoto thyroiditis, that is an autoimmune disorder that often presents as a firm or hard goiter of variable size. Next, we have Riedel's thyroiditis. It is a rare disorder that typically occurs in middle-aged women. Riedel's thyroiditis. It presents with insidious, painless goiter with the local symptoms due to the compression of the esophagus, trachea, neck veins, or recurrent laryngeal nerves. There is dense fibrosis that disrupts the normal gland architecture and can extend outside the thyroid capsule. The thyroid dysfunction is common and the thyroid gland is hard, non-tender and often asymmetric and is fixed, leading to the suspicion of a malignancy. Diagnosis required open biopsy. The treatment is directed to surgical relief of the compressive symptoms. So this was all about subacute thyroiditis or complete thyroiditis, acute, subacute, and chronic. And in the next lecture, we will be talking about goiter. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.